Good evening, and thank you everyone for joining us today. I, Ankit Dogra, along with my teammates Dr. Deepika Chabra and Mr. Amit Saxena from Medical Services Jagsonpal Pharmaceuticals Ltd, are delighted to welcome you all to the program today by Delhi PG Forum of AOGD with the case presentations on endometriosis by the postgraduate medical students of Hamdard Institute of Medical Sciences and Research, Delhi. The academic partner for today's program is Jagsonpal Pharmaceuticals Ltd, the makers of LycoRed soft gel capsules containing world process patented complex lycometo, all natural extract containing lycopene along with zinc and selenium to reduce oxidative stress and protect the cells. Our other brands are EndoReg tablets of dienogest 2 mg for the medical management of endometriosis and endometriosis associated pelvic pain, and CycloReg CR10 tablets of controlled release norethisterone for dysfunctional uterine bleeding, dysmenorrhea, and endometriosis. Dear attendees, if you have any questions, suggestions, or clarifications, please post them in Q&A box. Please note this class of the PG Forum is streaming live on the Facebook and the link has been shared in the chat box. To refer to this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. We express our sincere appreciation to the AOGD office bearers and the coordinators of Delhi PG Forum for taking Jagsonpal Pharmaceuticals Ltd as the academic partner for the monthly programs. We welcome AOGD President Dr. Achla Batra, otherwise Dr. Shivani Agarwal, the PG Forum coordinator, to kindly initiate the program. Over to you, ma'am.
So thank you, Mr. Ankit. I welcome one and all to this class on endometriosis by Delhi PG Forum. Our chairperson today is Dr. Reva Tripathi, ma'am. Good evening, ma'am. Can we have the slide of? She is presently professor and head department of ObGy, HIMSR, and she retired as director professor from MAMC in 2017. She was former head of department of MAMC, and she is a very well-known academician and a very good orator. She has won several prizes from Foxy, AOGD, etc. She has around 65 publications, and her area of interests are high-risk pregnancy, maternal mortality, HIV in women, and gynae oncology. So welcome, ma'am. Our moderator today is Dr. Aruna Nigam. Dr. Aruna is professor and unit head, HIMSR Delhi, and she has over 200 publications. She's the editor of 4 books, and she is also a well-known personality with several awards and several Raj Sony gold medal for best paper presentation in endoscopy in AOGD and several other awards. So, and the co-moderator along with Dr. Aruna is Dr. Dina Khan. She would be joining. She is the assistant professor at HIMSR. And I think we quickly start our session. So I hand over to Dr. Reva, ma'am, for a few encouraging words.
Thank you for inviting me to this program. And it's an important topic which you've chosen. And I hope our postgraduates will do justice to it. And I don't think we need to have more of a discussion later. So I'm not going to talk too much at the beginning. And just let's get started. Thank you.
So over to Dr. Aruna.
Okay, thank you, Dr. Shivani. Thank you, Dr. Reva. So immediately we are starting with the case because this is a very important topic, and this entity is being encountered from adolescent till the age of 45 or more than so also. So we need to diagnose and we need to know the right management of the disease. So Dr. Anamika and Dr. Astha, our second year postgraduates, are going to take it with one of the cases. Right. So Dr. Astha, kindly present.
Today we're going to present a case on endometriosis. Mrs. ABC, a 31-year-old female, resident of Ekta Vihar, New Delhi. She's a 12th pass, housewife by occupation, belonging to lower socioeconomic class by modified Kuppuswamy classification. Her last menstrual period was on 5th of February 2022. And she came with complaints of inability to conceive for the last 12 years and gradually increasing pain during menstruation for the last 12 years. Patient complains of inability to conceive since the last 12 years. She has been married for 13 years, cohabitating since 12 years. She gets history of intake of some Ayurvedic and homeopathic treatment for infertility, nature of which is not known. No history of usage of any contraception. Coital frequency 3 to 4 times in a week. Mild pain during coitus is present. There is no history of suggestive of ovulation induction intake. The patient also gives history of pain during menstruation for the last 12 years. Pain starts 2 days prior to onset of menses and remains throughout the menstruation. Pain was gradually increasing in severity, progressive in nature, now severe enough to hamper her day-to-day activities. There is no radiation of pain. Pain is not associated with vomiting, fever, painful defecation, urination. She gets history of taking oral as well as injectable painkillers for the same. There is no history of prolonged use of drug for any pain relief. There is no history of weight gain, acne, excessive hair growth, breast discharge, no bowel and bladder complaints. No history of abnormal vaginal discharge, no history of headache, blurring of vision. Menstrual history. She attained menarche 14 years at age of 14. Her last menstrual period was on 5th of February 2022. She gives history of regular cycles, 30 days plus minus 3 days, lasting for 3 days, using 3 pads per day. Dysmenorrhea was present, for which treatment was required. There is no history of passage of clots or any history of intermenstrual bleeding. Husband history. Mr. ABC, a 35-year-old embroidery worker, 12 hours, is a chronic smoker, smokes 1 packet of BD per day since the last 15 years. He is also an occasional alcoholic, drinks 2 packs 2 times in a week since 10 years. There is no history suggestive of coital difficulties, erectile dysfunction, or loss of libido. No medical or surgical history. Past history. No previous history suggestive of diabetes mellitus, hypertension, thyroid disorders, tuberculosis, asthma, epilepsy. No history of previous hospitalization or surgery in the past. There is no history of any blood transfusion. OBS history. She's a nulli gravida. Married in 13 years. Non-consanguineous marriage. Contraception history. There is no history of usage of any type of contraception. Personal history. Patient has a normal sleep and normal sleep appetite, normal bowel and bladder habits, non-alcoholic, non-smoker, no history of allergy to any known substance or drug, no history of any chronic use of drug. Family history, not significant.
The general physical examination will be presented by me. The patient was conscious oriented to time, person, and place. She was afebrile. Her pulse was 88 beats per minute. Her BP was 112 by 70 mm of Hg. Her height was 155 centimeter and weight was 50 kg, making her BMI 20.8 kg per meter square. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or fetal edema was not present. In thyroid and breast, no abnormality was detected. In systemic examination, no abnormality was detected. Now the abdominal examination, on inspection, her umbilicus was central and inverted. All corresponding quadrants were moving equally with respiration. There were no scars, dilated veins over the abdomen, and her hernial orifices were intact. On palpation, there was no local rise in temperature. Mild tenderness on deep palpation in left iliac fossa was present. Around 8 centimeters cystic mass was present in the left iliac fossa, which was non-mobile. The lower margin of the mass was not reachable, and the mass was cystic in consistency with regular surface, and there was no organomegaly. On percussion, dull note was heard over the mass, and rest of the abdomen was resonant. On auscultation, normal bowel sounds were heard. Local examination, the external genitalia were normal. On speculum examination, cervix and vagina was healthy. There was no discharge of bleeding per vagina. On vaginal examination, cervix was posterior, uterus was normal size, anteverted, not non-tender. Right adnexa was free and non-tender. Left adnexa, 8 into 8 centimeters, cystic mass was palpable with restricted mobility, which appears to be the same mass which was felt per abdomen. The tenderness was present in the mass and the margins of the mass were regular. Uterus was felt separately. On the per rectal examination, same mass could be felt through rectal examination. And in PVR examination, no nodularity was felt, slight tenderness was present, and the rectal mucosa was free. Now, this is the visual analogous score of the patient. The pain, she rated her pain between 4 to 5, which is moderate.
Which pain was it?
Ma'am, dysmenorrhea. It was during her menses, ma'am.
Okay.
And the pain during ma'am coitus was mild, ma'am. For that, she rated 1 to 2. And summary, a 31-year-old female presented with primary infertility and dysmenorrhea with left adnexal mass, most likely a left endometriotic cyst.
Right. So we will move to further what we have done or what has been planned in this case later on. We go back to history. And Dr. Astha, you said she has a mild dyspareunia.
Yes,
So
ma'am.
can you tell me the causes and the types of dyspareunia?
Ma'am, there are two types. The first is the superficial and the second one is the deep. Ma'am, the causes of superficial are, ma'am, pelvic infection, vaginismus, vaginal dryness, ma'am, vulvar vestibulitis, ma'am, any skin lesions like lichen sclerosis or lichen planus. Ma'am, in the deep dyspareunia, we have endometriosis, chronic pelvic inflammatory diseases. Ma'am, we have adenomyosis.
So you said that in pelvic infection, there is superficial dyspareunia also and a deep dyspareunia also. You said in superficial dyspareunia differentials. You said no? It is pelvic infection. So
Mostly deep dyspareunia is present in chronic pelvic inflammatory disease.
okay, what do you mean by deep dyspareunia?
Ma'am, when pain is present in deep during the end of the coitus, ma'am.
Okay. So, and there is one history I saw that you have written history of headache and blurring of vision also. What for you have asked this thing specifically?
Hyperprolactinemia.
So why do you want to know regarding hyperprolactinemia?
Ma'am, she's a case of infertility since the last 12 years, ma'am. So, ma'am, we should rule out hyperprolactinemia disorders.
Okay,
But
so
she has no amenorrhea.
No, ma'am.
So is it that important?
No, ma'am. No, ma'am.
And there was
Ma'am,
no
Also,
history
when
of
you're
Start as
start
well, ma'am.
ma'am. But in
when
routine,
you're
we
talking about deep dyspareunia, you should also think sometimes of a non-gynae cause. Crohn's disease sometimes causes deep dyspareunia also. Rarely, but it can cause. So think of keep non-medical conditions in mind also.
Okay, ma'am.
And I would just like to advise the other postgraduates that please see the detailed way that they have described dysmenorrhea. Many times when students present a history, we don't get all the details of dysmenorrhea. It is just presented as dysmenorrhea is present. So when you have a patient of endometriosis, you must present it properly, give all the characteristics as they have given.
So, Dr. Astha,
Yes, ma'am.
what is the ideal way of describing the menstrual cycle as per AUB classification, system 1?
Ma'am,
You
according
know
to
AUB classification system?
ma'am,
How many systems are there?
two system, ma'am.
Okay.
Ma'am, the first system defines the terminologies, ma'am, which says about the frequency. So, if it's menstrual absent, is termed as absent. Normal cycles is 24 to 38 days. Infrequent is more than 38 days. Frequent is less than 24 days. Ma'am, then we have the flow, which is told by the patient is light, normal, or heavy. Ma'am, then we have the duration. Ma'am, the normal duration of cycle is less than or equal to 7 days. If it is prolonged, more than 8 days. Ma'am, then we have regularity. It can be, ma'am, regular or irregular. Regular, ma'am, the shortest to the longest variation is less than 8 to 9 days. And in irregular cycles, the shortest to longest variation is more than 8 to 10 days. Ma'am, then we have intermenstrual bleeding, which can be absent. It can be random or it can be cyclic, which can be mid, early, late. And ma'am, then there's bleeding due to intake of estrogen and progesterone tablets, which can be
Right.
absent.
Okay, so we can have a formula for all postgraduates, C drive. That means cycle length, regularity, duration, and then volume and intermenstrual bleeding. So in that way, all the 5 points are covered, and pain you have to cover separately, which has been given another row in the AUB system classification 1. So you need to know what is system 1 and what is system 2. So whenever we are talking of dysmenorrhea, this is a very important history. Whenever you are presenting a case of endometriosis and PID, right? So Dr. Astha, what are the types of dysmenorrhea you know?
Ma'am, there are two types of dysmenorrhea, which can be primary or secondary, or else we can classify them as spasmodic and congestive dysmenorrhea. Ma'am, spasmodic dysmenorrhea is present in the normal menses in everyone. It's a physiological type, whereas ma'am, congestive dysmenorrhea is a pathological type in which the pain starts 2 to 3 days prior to the menses, remains throughout the menses, and may even continue 1 to 2 days after the menses. Ma'am, it is mostly the pathological type. Ma'am, the causes of congestive dysmenorrhea are endometriosis, adenomyosis, ma'am, any fibroid, any infection.
Why fibroid will cause a
Any
pain?
fibroid? Oh, okay.
Ma'am, pedunculated fibroid, ma'am. Pedunculated fibroid.
So why there occurs a pain in the pedunculated, subserosal pedunculated?
Ma'am, submucosal pedunculated, ma'am.
Why not a subserosal fibroid will cause a pain? Pedunculated one. Can it cause a pain?
Any torsion in the ma'am?
Yes. So whenever there is a torsion, the subserosal fibroid can also cause a pain, but it is generally the submucosal one, which is pedunculated. Uterus has a tendency to expel out anything which is inside. So that's why it causes pain. Dr. Dina, do you want to ask anything?
Anything specific you would like to take in your family history?
Ma'am, family history related to endometriosis, ma'am, because endometriosis has 7 times higher chance in first degree relatives, ma'am. So we would like to ask if any mother or any sister is having endometriosis or not, ma'am.
So did you ask in your case?
Yes, ma'am, we did, ma'am.
So how many siblings were there in this case?
Ma'am, the patient had only one sister. The sister as well as the mother. Ma'am, there was no history of any endometriosis or any infertility, pain during menses. Ma'am, no history.
Okay. So can you tell me the method of quantification of amount of blood loss during menses?
Yes, ma'am. Ma'am, there's a score which is known as PBAC score, which is pictorial blood assessment chart. Ma'am, the patient, ma'am, we quantify the blood in the total menstrual cycle. Ma'am, the patient is using pads. We give 0.1 as minimally soaked pad, 0.5 as moderately soaked pad, and 0.20 for completely soakage of pad. If the patient is using tampons, 0.1 is given for minimally soaked, 0.5 is given for moderately soaked, and 10 is given for completely soaked. If she's given history of passage of clot, 0.1 is given for the small clot and 0.5 is given for the large clot. So in the entire cycle, all of them are added together. And if the score is more than 100, it refers to a heavy menstrual bleeding.
We have one picture for that.
Okay, so how much relates to heavy menstrual bleeding?
More than 100.
Okay. Dr. Dina, do you want to ask anything else?
I think you can proceed.
Okay. So let's move. Examination is very important whenever we are doing a case of endometriosis. So you said Dr. Astha, Dr. Anamika has presented this examination. So you said PVR examination. How do you perform a PVR examination?
Your examination is performed with the help of ma'am index finger and middle finger. We put on gloves and then put on lubricant, and we insert the index finger into the vagina and the middle finger into the rectum. And then we first feel for the rectovaginal septum for any thickness, any nodularity. Then we move our finger sideways to see the cul-de-sac and pouch of Douglas, ma'am, to see for any nodularity, tenderness. And,
Nodularity, why do you get nodularity?
in
case of endometriosis?
Ma'am, deep endometriosis, we can get nodularity in the cul-de-sac, uterosacrals. We also check uterosacrals at 4 o'clock and 8 o'clock position, ma'am.
What is the extent of uterosacral ligament?
It extends at the base of the cervix. Base of the cervix.
Base of the cervix? बस वहीं पे लटक गया और कहाँ होता है? What is the length? Extent of the uterosacral ligaments? Only then you can appreciate this nodularity, na? So from where to where uterosacral ligament is extending?
It attaches
Take a hint from the name.
It attaches to the pericervical ring.
Yes. And posteriorly?
S2, S3, ma'am.
S2, S3, S4. That is very important. In each and every case, you will be asked about whatever gynae case comes, most of the times uterosacral ligament will be asked to you, right? So in which condition you can get findings in PVR examinations?
Ma'am, we can get ma'am nodularities and tenderness in case of endometriosis, in case of deep endometriosis, ma'am. And then we can also get ma'am findings in CA cervix, where we can get ma'am rectal mucosa can be involved, parametrium can be involved, pelvic walls can be involved. So in that cases we can get, and also in cases of ma'am prolapse, PVR examination is helpful in distinguishing between enterocele and rectocele.
Okay. So you said that rectal mucosa can be involved in CA cervix when the rectal mucosa is not mobile. Any other condition where there can occur immobility of the rectal mucosa? Very severe case. Okay, I'm asking in another way. Can you tell me what is deep endometriosis?
In deep endometriosis also, ma'am, the rectal mucosa is not mobile. And when the depth of the endometriotic implant is more than 5 mm, and it is known as deep endometriosis.
So when it can occur that the rectal mucosa mobility will be less?
And when the deep endometriotic implants are on the rectal mucosa and the patient is having pain because of that, ma'am.
Or the involvement is between the rectovaginal fascia. It is first the rectovaginal fascia which is involved, and then there is a move towards, and that is a very difficult condition to operate upon. But that is very rare, but still that you can find. So you have a adnexal mass, right? I can find you have written 18 to 8 centimeter cystic mass. Why are you after it that this is endometriosis, endometriosis? What is the differential diagnosis of adnexal mass?
The patient came with pain and infertility for 12 years and pain during menstruation, ma'am. And the type of pain that she described was, ma'am, it was secondary dysmenorrhea. And also there was a mass. So, ma'am, these things pointed out towards endometriosis, ma'am. Infertility plus pain. The patient is in reproductive age group.
Which makes a classical triad of endometriosis, ma'am, which is infertility, dysmenorrhea, and dyspareunia. So, ma'am, we have all three of them. Along with that, we also have a mass, ma'am, which is suggestive of endometrioma.
Okay, if there is a mass and the adnexa, infertility नहीं होती, तब क्या differentials बनती?
Ovarian tumors के हो सकते थे, chronic ectopic हो सकता था, chronic PID.
Leiomyoma uterus, which can be broad ligament.
Leiomyoma.
Okay, और क्या?
Hydrosalpinx,
pyrosalpinx.
Can you tell me about the true and the false broad ligament fibroid? What is the difference between them?
Ma'am, the true broad ligament fibroid is actually the broad ligament fibroid where the fibroid develops in the broad ligament, whereas, ma'am, in the false broad ligament fibroid, ma'am, it is an extension of the uterine fibroid which is lying in the broad ligament, ma'am.
So one very important structure is there which has to be taken care of whenever there is a broad ligament fibroid, especially the true broad ligament fibroid. So what is that structure and what is the position of that important structure in relation to these?
Ureter, ma'am.
Perfect. Priyanka has also typed ureter. So can you tell me the relation of ureter in both the type of fibroids, although I'm going away from endometriosis, but these are the questions. It's not necessary that it is a case of endometriosis. So examiner is going to ask you about endometriosis. अगर उसे लगा कि endometriosis तुम्हें बहुत अच्छा आता है तो वो दूसरी तरफ चला जाएगा. ठीक है? So tell me the relationship of the ureter.
Ma'am, it is medial in, ma'am, true broad ligament fibroid. Medial. True broad ligament.
Yeah, very right. Medial in true broad ligament fibroid. क्योंकि broad ligament के fibers से आ रहा है ना. So then the next question will be on the ureteric course, right? So I'm not going into the detail of that. Dr. Dina, will you like to ask anything, or we will move towards the investigation?
Ma'am, this differential diagnosis, what is the most probable diagnosis in your case? And how do you arrive at it?
Points in favor of your diagnosis.
Ma'am, the infertility for 12 years dyspareunia, dysmenorrhea. These were the, though there is no family history and the cycle lengths are also normal, ma'am. The cycle length is not shortened and the duration is also normal, but because of infertility and pain, we pointed towards endometrioma and the mass was big.
So what are the investigations you would like to do to confirm your diagnosis?
The first investigation we'll like to do is ma'am, ultrasonography, transvaginal sonography, ma'am.
Okay. Transvaginal, you will prefer over transabdominal.
Yes, ma'am.
Okay. Why is it that? Why so?
Ma'am is saying something.
Abdominal mass, you want to start with the transvaginal sonography?
But not in the normal mass, but ma'am, in this
No,
case,
your patient has an abdominal mass. Didn't you say so?
yes, ma'am.
So despite having an abdominal mass, you want to start with the transvaginal?
No, ma'am, we can start with the transabdominal sonography.
We can
Why?
start.
How do you decide? How do you decide what should be done?
Transabdominal ultrasound, and ma'am, we will also do a transvaginal ultrasound to rule out any deep into any other pathology if we can find.
Suppose on ultrasound, your sonologist say it is a hemorrhagic cyst. Can what are the findings that you can find in each hemorrhagic cyst and endometriotic cyst?
And hemorrhagic is the size is
Can
not,
it be confusing?
Yes,
ma'am,
ma'am.
it can
Yes.
be.
On ultrasound, it may be confusing.
Yes, ma'am.
But endometriotic cyst would give a typical ground glass appearance.
Yes, ma'am. In endometrioma, we can see the ground glass
Glass
opacities, ma'am, which is because of the uniformity.
And there will
And
be
no
no
Doppler, ma'am.
no color on color
Doppler changes.
ग्राउंड ग्लास को डिस्क्राइब कर सकते हो किसी चीज का एग्जांपल देकर? ये तो बड़े कॉमन सा है, ग्राउंड ग्लास होता क्या है? ग्राउंड ग्लास देखा है कभी रास्ते में चलते चलते? यस, दैट इज वेरी इंपॉर्टेंट. ये जो सिम्बलीज दी जाती है ना, तो उनका मतलब भी आना चाहिए. दिस इज वेरी इंपॉर्टेंट. व्हाट इज ग्राउंड ग्लास? बिकॉज यू पीपल आर नॉट गोइंग टू गेट योर हाउसेज मेड राइट नाउ कि खिड़कियों में कैसे शीशे लगने चाहिए. So do you want a shisha you want to see arpar along your mirrors, or you want that nobody should be seeing you?
Nobody should see.
So that glasses which are there, those are ground glass. Homogeneous appearance होती है, दाने दाने से दिखाई पड़ते हैं. That is homogeneous appearance. That is a ground glass, right? वो नहीं जिसमें कि जगह जगह बड़े सारे डायग्राम्स बने होते हैं. It's a ground glass. Typically you have to see, and now whenever you move from your corridors, just see which glasses are ground glasses. Okay. So shall we move further? What were the investigation in your case?
Ma'am, we did a routine investigation for the blood group, hemoglobin, CBC, blood sugar, fasting PP, serum TSS, serum prolactin, CA125, which were all within normal limit. LFT and KFT was also done. PT-INR and urine RM were done, which were all within the normal limit. And histopathological examination was also done, and in which endometrium was in late secretory phase. Then staining was negative, and AFP culture backtech was also negative. And pap smear was done, in which there were no intraepithelial lesions.
Anamika, CA125 is normal?
No, ma'am,
No,
it is
ma'am.
increased, ma'am. 166, it is increased, more than 35.
So you said it's normal, no? That's why I'm saying.
Ma'am, it is increased, but in cases of endometriosis, but we get higher values of CA125, but it is not specific.
So what are the causes of
Thus-
raised CA125?
Thus, it is not exorbitantly raised. That is the most important thing. Because once it is raised, then you need to look at how much it is raised, because the idea of malignancy always has to be at the back of one's mind when one is thinking of a CA125. So it is not very high. That is the important thing that you need to remember. There is a comment I just read about that there is no role of CA125 in endometriosis. Whoever made that comment is correct. It's not got a diagnostic role, but once you have an adnexal mass, then evaluation of a CA125 cannot be considered extraneous. So keep that in mind.
So doctor, let's discuss this thing because everybody has in mind that why we get a CA125 done. So there are many other tests you got done. Why?
Ma'am, we didn't get other tests done, ma'am.
Huh? Why you got blood sugar fasting, PP?
Ma'am, for the routine, ma'am, because the patient was to be taken for OT, ma'am. So these were the routine investigations to be done.
Okay, why you got a histopathological examination done of endometrium?
Ma'am, because the patient is of infertility and the most common cause of infertility in India is, ma'am, tuberculosis, to rule out the ma'am.
Why don't you think that this this ovarian mass or a tube ovarian mass could be because of tuberculosis?
And also because of
So you want to rule out that thing also. Now coming to back to CA125, what are the causes of the raised CA125?
125 can be raised during pregnancy. It can be raised during menstruation. It can be raised during ovarian tumors. It can be also raised during fibroids, if fibroids are present. And then, ma'am, in liver cirrhosis, in cases of lymphoma, that can be raised, ma'am.
Peritoneal carcinoma, peritoneal tuberculosis, whatever things are involving the peritoneum, they all will cause a raised CA125, right? So now tell me, if any patient you get of a adnexal mass, any other biomarker can we do?
We can get CA19, CEA, beta, HCG, inhibin A, B, LDH, alpha fetoprotein. Now we can get them done as well.
Okay, Dr. Astha. Nice. Dr. Astha, you are sitting in a private medical college. Is it all free?
No, ma'am.
So now, how will you decide about these all biomarkers? Where to get it done?
Ma'am, when the suspicion is towards, ma'am, ovarian carcinomas or ovarian mass, ma'am, when the size of the mass is too big, ma'am, like when we are suspecting a mucinous mass, ma'am, then we can do these.
All mucinous mass
with the large size.
So what are the factors which they decide that which markers have to be done?
Like
one is in blanket, you write down 5,000 10,000 रुपए लगेगा चलता है, but no, you have to decide. So how can you just decrease the number of tests by just yes,
history, by patients, radiological investigation, and by from an ultrasound we'll get an idea, from a clinical examination we'll get an idea, and according to that, ma'am, we will filter out the tumor markers which needs to be done, ma'am.
So is age relevant to know? Yes. Yes,
ma'am.
So what is the relationship of age and getting all biomarkers done?
In less than 30.
Ma'am, in less than 30 years of age, we can get a HCG, inhibin A, LDH, alpha fetoprotein done, ma'am, because dysgerminomas, immature teratomas, yolk sac tumors are common in age less than 30 years of age, and these are the tumor markers which will increase.
Yes. So if it is more age, then you can just skip these. You can get done in a different steps, right? And according to the ultrasound findings also, which type of tumor it is, solid tumor, cystic tumor, complex. So do you know any scoring system for the same?
There is RMI system, then there is Roma scoring system, IOTA scoring, and ENDOReg scoring system.
So what is the latest one?
IOTA scoring, simply scoring.
What is this IOTA?
International Ovarian Tumor Analysis Score, ma'am.
So what it considers? Does it consider CA125?
No, ma'am. It is based on ultrasonographic findings, ma'am, and there are features. It is divided into benign, malignant, and, ma'am, inconclusive. In benign and malignant, there are 5 groups, and according to that group, which are based on ultrasonographic findings, and according to that, we classify.
So there are many scoring systems which are now coming, adnex modeling, IOTA scoring, all these are coming. So you can go whenever there is adnexal mass, this can be asked to use. So we move further. Why you got a pap smear done?
Ma'am, it was an opportunity for us, ma'am. The patient was coming, ma'am. So we did a pap smear also.
19 की होती तो भी कर लेती.
Ma'am. नहीं करते मैम 25 के ऊपर करते हैं.
चलो आगे चलो let's move further.
She had a SSG which was done in 2015, and in that SSG no films were available. There was one report in that no spill was seen and no filling defect were seen in the uterus. On her ultrasound findings, ma'am, the uterus was normal size, 6.4 into 3.7 centimeter, anteverted. EP was 12 mm. There was normal echo texture of the myometrium. Right ovary was normal in size and echo texture. A 7.2 into 5.5 into 6 centimeter well-defined anechoic cyst with low-level echoes was noted in left retronexa, which was abutting left ovary and show minimum to no vascularity on color Doppler, and there was minimal mild free fluid in the fibula. Then the husband semen analysis was done and it was normal, ma'am. Then we planned the patient for histolaparoscopy and proceed.
Why did you plan directly for operative procedure for the patient? Did you not try any other modality before approaching it operatively?
Because the patient is giving a lot of history of pain, ma'am. If she was giving just history of infertility, then we would have tried other modalities, ma'am. But the pain is also one of the main features of the patient's history, ma'am. That is why we're planning for the operative procedure, ma'am.
And she also had infertility for such a long time. So, ma'am, by this way we can make a diagnosis and we can manage her accordingly, ma'am.
And her HSG also shows bilateral block.
Yes, ma'am.
Okay.
You had said you have made a diagnosis of endometriosis, but your ultrasound is showing anechoic cyst?
Yes, ma'am. It was written anechoic only, ma'am, in the ultrasound.
So does that make you think of something else? Would you like to reconsider your diagnosis of endometriosis, or will you like to do something else? How are you so sure about endometriosis with an anechoic cyst? You are right that the history is suggestive a lot of the endometriosis, but your ultrasound pictures is not corroborating it.
Yes, ma'am.
So
that's why we went for histolaparoscopy to confirm the diagnosis also.
No. What now? This is wrong. If you have been asked to tell the differential of the anechoic cyst, you need to tell that. So what is the differential for the anechoic cyst in ultrasound? Is it necessary to perform laparoscopy in each and every case to confirm your diagnosis? No. So what is the differential for the anechoic cyst? That's why it is very important. In the exams, when you are said, tumko endometriosis ka case mila hai, your whole mind goes towards endometriosis and you don't think anything else. Right? So what is the differential for the anechoic cyst? कौन सी cyst हो सकती है? सबसे Okay, it is not generally anechoic. What else?
Hemorrhagic.
Simple anechoic cyst. What is the differential?
Dominant follicle, ma'am. Just forming.
so big.
Forming, ma'am.
Your 9 centimeter. How many centimeter? 8 centimeter.
9 centimeters.
Are you talking functional cyst? What are you talking?
Functional cyst, ma'am.
So with this size, what was the size you said? Just go back.
Ma'am, 7 into 5 into 6 centimeters.
So will you call a cyst this large as functional?
No, ma'am. No, ma'am.
So now what next? Day in day out वो cyst देखते ऑपरेट हो रही होती है, क्या होती है वो? अरे common cyst ovary की what is that? SSC. Simple serous cyst नहीं हो सकती?
Yes, ma'am.
What else? What else? Please go on writing the differential for the anechoic cyst in the chat box. We'll see to it. Okay, we will move further. Dr. Dina, just take care of what differential they write down. Huh.
Ma'am, for the lab findings, ma'am, in this we can see the endometrioma along with the left tube, ma'am, and superficial implant on the left tube as well.
Okay.
Ma'am, this is in a laparoscopy picture showing us the endometriotic implant on the appendix, ma'am.
Where is appendix? Can you use your cursor to show it? नहीं आ रहा cursor? नहीं आ रहा, तुम्हारे स्क्रीन शो पे तो आ जाता है, नीचे लेफ्ट साइड पे ले जाओ. Okay, no problem. Go back, just show, describe this previous slide.
Yes, ma'am.
Yeah.
This is
Previous slide. Previous slide. Yes.
Ma'am, this is a laparoscopy picture showing us the endometriotic implants on the appendix, ma'am.
Okay.
Ma'am, the whitest structure that we can see is the appendix, ma'am.
Just above yellow part.
Yes, ma'am.
Curved one.
The one spots can be seen.
And because of this, appendix appears to be adherent to the peritoneal wall, no? Lateral wall. Right. What next?
Ma'am, this is a laparoscopy picture showing us the endometriotic implant on the sigmoid colon, ma'am.
Okay.
And just above the picture, we can see a blackish spot, ma'am. Ma'am, then this is a laparoscopy picture showing us the endometriotic implants on the right ovary, ma'am. Superficial.
Is something there in the beneath this ovarian ligament also? So why I said this, because you have to thoroughly examine your peritoneal cavity to see the spots, because that is the thing you need to take care of once you further move for the treatment.
Okay.
Now there is one endometrioma picture. Okay, you have not shown the POD. We could not see. Okay, move further.
And on hysteroscopy, the uterine cavity was of normal size and both ostia were visualized and endometrium was normal.
Why do you did a hysteroscopy in this case?
Ma'am, because no spill was seen, ma'am, in the HSG.
अच्छा spill मिल जाती तब क्या करते, नहीं करते hysteroscopy?
भी करते, ma'am.
So why you did a hysteroscopy?
The morphology
of the uterus, ma'am.
Why you want to know the morphology?
Patient is giving history of infertility since the last 12 years.
Mullerian abnormalities are one of the causes of infertility as well as endometriosis.
Okay, what Mullerian anomaly you get to know in a hysteroscopy?
If there is a septum, we can see.
And
if
arcuate uterus, any septum, transverse septum, longitudinal septum.
Diadelphys, ma'am, in uterine diadelphys.
Unicornular, you will find only one ostia, but that has to be supported by a laparoscopic findings, right? आगे चलिए.
On laparoscopy, multiple endometriotic spots were seen all over the peritoneum and right ovarian surface, pouch of Douglas, bowel and appendix. Left ovary 6 into 7 centimeter. The sigmoid colon was densely adhered to posterior surface of the left ovary, posterior surface of uterus and left uterosacral ligament. Right ovary was on right ovary, small endometriotic spots were present. Uterus and right fallopian tube were normal. Chromoperturbation was done before surgery and no spill was seen. After that, adenolysis was done, followed by fulguration of the endometriotic spots using bipolar cautery. Then the drainage of cyst was done, followed by cystectomy. After the procedure, chromoperturbation was done again and bilateral spill was seen.
Okay.
Now, this is the picture showing, laparoscopic picture showing the fulguration of the superficial endometriotic spots on the right ovary.
Okay.
Bipolar. And this is the picture where the cystectomy is in process. The yellowish tissue which we can see is the cyst wall and the whitish tissue is the ovarian tissue.
Okay. Now what?
Ma'am, now according to our surgical laparoscopic findings, we have scored the patient according to the revised American Society for Reproductive Medicine scoring system. And this scoring system divides the stages of the endometriosis into 4, the stage 1, 2, 3, and 4. 1 is the minimal disease, 2 is mild, 3 is moderate, 4 is severe disease. And in this classification, the endometriosis is defined in the ovary and the peritoneum. Then the obliteration of the cul-de-sac is scored, and then adhesions are scored on the basis of tubes of both the side and ovaries of both the sides. So in our patient, in the peritoneum, there were deep endometriotic implants less than 1 centimeter. The score of 2 is given for that. In ovary, right ovary, superficial implants were there which were less than 1 centimeter, so the score of 1 is given. There were no deep endometriotic implants on the right ovary. On the left ovary, there were no superficial implants, and on deep implants which were present were more than 3 centimeters, so a score of 20 is given. The posterior cul-de-sac was partially obliterated, for which the score of 4 is given. And adhesions, in the right ovary, there were no adhesions, either flimsy or dense. In left ovary, dense adhesions were present, which were enclosing more than 2/3 of the ovary, and so the score of 16 is given.
Yes.
In the right tube, there were no adhesions. In the left tube, dense adhesions were present, which were enclosing 1/3 to 2/3 of the tube, and for that 8 was given. On these, the total score was 51, and the stage of the disease was, ma'am, moderate severe.
So when you do a scoring, at the start of surgery or at the end of your surgery?
Ma'am, there are two things, ma'am. In this, we are doing, in this revised system, we are doing the scoring at the start of the surgery.
So always this is done at the start of surgery. Then what is done? What is
then ma'am, we have to calculate the endometrial fertility index, for which we need a least function score, which is done after the end of the surgery, ma'am, to see.
Okay.
Improved, ma'am. So for endometriotic fertility index calculation, there are two divisions, ma'am. First is it contains historical factors, and second is the surgical factors. Then historical factors is take the age of the patient. If the age of the patient is less than 35 years of age, then the score of 2 is given. If age is more than 35 to 39, the score is 1, and if it is more than 40 years, the score is 0. Then in historical factors, the years of infertility are also accounted. If the patient is infertile for less than 3 years, then a score of 2 is given. If it is infertile for more than 3 years, a score of 0 is given. If the patient has been pregnant before, the score of 1 is given. And if there is no history of any pregnancy, the score of 0 is given. And then for calculation of the surgical factors, we need least function score, AFS endometriotic score, and the total score. So for least function scores, ma'am, there are 4 scoring, 4, 3, 2, 1, 0, which are dependent upon the function which are attained after the surgical correction. And in that, both the sides of the fallopian tube, fimbria, and ovaries, they are classified, given a score based on their function. And in our case, ma'am, both the fallopian tubes, both sides were functioning normally after the end of the surgery. The fimbrias were normal after the end of the surgery. The right ovary was also normal. In left ovary, we have given a score of 2. That is a moderate dysfunction, because during cystectomy, ma'am, some amount of healthy cortex of the ovary is also removed. And after the closure of the ovary, ma'am, the morphology of the ovary was looking fine, ma'am. So we have not given it severe dysfunction or absent function, but we have given it a score of 2 for moderate dysfunction.
So we close the ovary at the end of the surgery?
No, ma'am, only the cyst wall, ma'am. We don't close the, ma'am. We remove the cyst wall.
In laparoscopy, we don't do the reconstruction of the ovary as such, because what happens is the cortex goes inside. So we don't do that. Otherwise, in open, generally we are doing a reconstruction, but as such in laparoscopy, we are not going for a reconstruction, just a oozing places for tries. So why you did the EFI?
The EFI gives an approximate idea of non-IVF conception of the patient, ma'am, after the surgery. What are the chances if the patient is trying to conceive, ma'am, not by IVF, but by ovulation induction or by IUI, ma'am. So So it gives an estimate for the treating surgeon also, and it gives the satisfaction to the patient also, that she knows her chances.
Okay, what does this score does not contain?
And pain.
Pain does not contain. So is it recommended by any latest society? Is it? Yes.
She is recommending this only, ma'am.
Which society is recommending?
Ma'am, history guidelines have recommended the staging based on American Fertility Society, ma'am.
So ASHRAE has recently recommended that we should be including EFI routinely in our surgeries.
Yes, ma'am.
Right. So next.
And what is the
Yes.
difference between ASRM and AFI scoring, AFS scoring?
And both are same society.
AFS scoring and ASRM are the same.
Both are same.
एक ही सोसाइटी के दो नाम हो गए ना, ठीक है. Okay.
Any
so,
other classification system, you know?
In Jain classification.
It is for deep endometriosis. In this, ma'am, 3 compartments are divided. Ma'am, the first compartment consists of the rectovaginal septum. The second compartment consists of uterosacrus, and the third compartment is the compartment C. It consists of the rectum. And then, ma'am, on the basis of the endometriotic implant size, it is divided into grade 1, 2, or 3, less than 1 to 3 mm, and more than 3 mm.
And then we also have
F-
FA for
F-
adenomyosis, FB for bladder, FU for ureter, and FI for intestinal
FO for
endometriosis, and
others.
FO for
Others.
what are the problems which we face when we are operating these endometriosis, severe endometriosis?
A lot of adhesions are there.
So what?
Anatomy is distorted.
Yes.
And then, ma'am, if we are doing cystectomy, there are chances then that we also take along with the cyst wall the normal ovarian tissue. So ovarian reserve in these patients is already low. And
So something could have been done in this case before doing the surgery?
We could have done AMH and total
and follicular count.
Okay, so AMH is a good thing to do pre-operatively, just to show that how much reserve you have taken out.
Yes.
Right?
What was the reserve initially also?
Initially of the patient. Okay. So now what's the plan?
For this patient, we have planned time intercourse with ovulation induction for next 3 cycles, and after that, ovulation induction with IUI for the next 3 cycles.
Okay, and then?
Ma'am, if she doesn't conceive, then we can refer her to the IVF center.
Okay. What are the precautions which one should go for whenever we are doing a cystectomy?
Ma'am, a very thin cyst
Cyst
wall
wall
should
should be
always be removed, ma'am.
Why?
Ma'am, so that we
take the minimum
ovarian tissue.
Minimum ovarian tissue or something else?
So that, ma'am, the anatomy of the ovary is maintained, the morphology is maintained, and we're not decreasing the ovarian reserve for the patient, ma'am.
So what is removed because of which ovarian reserve decreases?
The cortex. Ovarian cortex.
Yes. I have beautifully explained in my lectures, which is on my website regarding all these things. You can go for this because the periphery contains the ovarian follicles, right? So that is being removed whenever you are performing a cystectomy. That's why thinnest part has to be removed whenever you are performing a surgery. So your case has got an endometrioma, right? Can you tell me the types of endometriomas?
2 types are there, type 1 and type 2. In type 1, if the endometrioma develop from the endometrial implants on the ovary, then it is type 1. Type 2 is when the functional cyst is intake by the endometriotic implant and then it develops into endometrioma, then it is type 2. Then type 2 is further divided into 2A, B, and C, depending upon the upon how much the cyst wall is involved. If less than 10% of the cyst wall is involved by the endometriotic implant, it is 1A, 2A. If 10 to 50% is involved, then it is 2B. And if more than 50% of the cyst wall is involved, it is 2C. 1 and 2C. In these, the cyst wall is adherent to the ovary, and it's very difficult to find a plane and remove it. In 2A1, 2A and 2B, it is easier to remove the cyst wall.
Okay, Dr. Rumi, you can type your question in the chat box. That will be better because you have raised the hand. So what is the gold standard for the diagnosis of endometriosis?
Earlier, it was laparoscopy followed by histopathological examination, but in recent ISHRA guidelines, they have not recommended the histopathological examination. They have only mentioned about laparoscopy.
No, I think you are wrong.
Laparoscopy is also not the gold standard according to ISHRA.
Yes.
It doesn't specify any investigation as the gold standard.
Nothing is now gold standard, because even if on laparoscopy we don't get an endometrioma, ma'am, if the patient is having pain there.
Okay. So in which cases it is good to do this IUI or ovulation induction?
One and
stage
2
2
of endometriosis, we should go for
IUI,
and in stage 3 and 4, we should, it will be better that if we go for an IVF directly, ma'am. But if the patient is not affording, then ma'am, we can still give 3-cycle trial of ovulation induction with IUI.
It also depends upon the tube patency and husband semen analysis, ma'am. If they are normal, then even in stage 3 and 4, we can try for ovulation induction and IUI.
Why there occurs infertility in endometriosis?
Ma'am, there are different factors. Ma'am, there can be anatomical factors, ma'am, ovulatory factors, inflammatory markers, ma'am, and peritoneal fluid biochemical markers. Ma'am, in anatomical markers, they can be tubo-ovarian relation is disrupted. Ma'am, there can be chronic salpingitis. Ma'am, there can be adhesions and defective oocyte pickup. Ma'am, in ovulation dysfunction, it can be, ma'am, anovulation, defective folliculogenesis, in defective implantation. In biochemical changes, they can be, ma'am, increased production of cytokines, prostaglandins, increased activity in macrophages. Ma'am, in immunological factors, they can be increased autoantibodies. Ma'am, then in endometriosis, they can be, ma'am, decreased intercourse due to dyspareunia.
Also, there are more chances of miscarriages.
Defective fertilization.
Okay, Dr. Dina, do you want to ask something?
What are the findings do you get on your HP examination?
Ma'am, it will be endometrial glands and stoma with or without
hemocytin-laden macrophages.
And when do you decide to operate it?
If the patient is in too much of pain and has not responded to medical management, if the patient has infertility and she has gone all the medical management, and if they, sometimes if the patient is asymptomatic also, but the size is more than 5, that is controversial, because somewhere is given more than 4, somewhere is given 4 than 3. And also if on VAS, VAS is scoring, if the score of pain is more than 7, then we go for surgical management.
So if I ask you 3 factors during the decision for the treatment of endometriosis or a mode of treatment of endometriosis, can you tell me those 3 factors?
Can you repeat your question?
3 factors which basically decides your mode of treatment in case of endometriosis. There are many, but main 3.
Pain, the complaints of the patient, whether it's pain, infertility, or the lump that she can feel,
age, fertility issues, and pain.
Fertility.
Age, pain, and fertility.
Dr. Shailesh Jadbuke has said that this lecture is like Viva. So this is a case presentation and there is going to be a Viva only, not a lecture, right? Okay. So when do you operate? Suppose there was no fertility issue. Patient had an endometrioma, which is asymptomatic, around 5-6 centimeters. So what are the criteria? What are you going to do with this patient?
If the patient is asymptomatic and she is not having any fertility issues, then we can do nothing and we can go for a wait and watch policy.
Reassess the patient
periodically to see if it is growing or not. The size is increasing.
So what are the complications which can occur with the persistent ovarian endometriomas?
Rarely it can
Adhesions, and ma'am, very,
adhesion,
very rarely it can lead to endometrioid or clear cell adenocarcinomas. But it is very rare, ma'am.
So one thing can occur, you said increase in size, adhesion, what else? Very rarely again.
Cancer, torsion, infection.
Is endometrioma is prone for a torsion?
No,
Do you
ma'am.
think?
No,
Why?
ma'am.
Why not?
Broad base.
it can.
It can? Why?
No.
No, it cannot, ma'am, because it has a broad base. It is implanted on the ovary only, ma'am.
And adhesions are also,
So what?
Adhesions.
Yes.
Ma'am, adhesions are also present, ma'am. It is
This is the benefit. Additions are there. So they will not allow it to rotate.
Which type of cyst is prone for torsion?
dermoid cyst, ma'am.
You're asking?
Ma'am, dermoid cyst.
Yes. Anyone? Why? What is the reason? Just off the track. Anyways.
What about medical management?
Medical management, we can start with ma'am pain relief and ma'am OCP.
When do you want to start? In which are the patients in whom it should be started?
Indications of medical management. When will you do?
So there is no fertility issue. Adolescent girls, ma'am, with endometriosis in them, those who have completed their family perimenopausal women, ma'am, with endometriosis, those patients we can start medical management.
If the cyst wall is less than.
What is the aim of your medical management?
To relieve the symptoms and pain.
To relieve the pain of the patient.
So what should be the aim? To relieve the symptom, वो तो मालूम है तभी तो दे रहे हो. So what is the aim, goal of treatment? हम हर treatment से what we want to do something.
Decrease the estrogen levels, ma'am.
Ma'am, it also decreases the size of the cyst, ma'am.
But medical management can cause atrophy of the implant, but it does not eliminate them.
What and management you know?
Yes, ma'am.
What medical management can be used?
We can start with the
the
painkillers,
followed by OCPs. Painkillers combined with OCPs, ma'am. Then we can, if it is not relieved by this, then we can go for second line of management, which includes GnRH agonist, ma'am, GnRH antagonist. Then, ma'am, we have progesterone, ma'am.
selective progesterone modulator receptor, ma'am. Then we have aromatase inhibitors, ma'am.
What newer progesterones are there and how do you prescribe the OCPs in these cases?
We should always give a continuous regime of OCPs.
Cyclic and continuous
Can
can
be,
be,
but we
both
can
can be
prefer-
given, but continuous regime is preferred, ma'am. And
Why?
the progesterone, ma'am, because it creates a long period of amenorrhea, ma'am, and there is no withdrawal bleeding.
Right?
And for newer generation of progesterone, ma'am,
Dienogest.
fourth generation progesterone dienogest is there, ma'am. 2 milligram daily doses for 3 to 6 months. We can.
What is the advantage of dienogest?
Ma'am, there's no vasomotor actions, ma'am.
And one very common side effect occurs with OCPs also, with other progesterone for second generation.
Weight gain, hot flushes, mood changes,
hirsutism,
mood changes.
Water retention. So that is not there with the dienogest. Do you know any OCP containing the dienogest?
3 days, 3 days.
Some OCPs are there with the dienogest, so that can also be given. Why we want to give small dose of estrogen also? What does progesterone, long-term supplementation of the progesterone causes? Somebody has written breakthrough bleedings. So continuous progesterone can cause this thing. So small amount of estrogen helps, right? And which other progesterone you can use? All the progesterone can be used or specific type of progesterones you want to use?
The progesterone acetate is
Can be given. Yes. Any other device can be used?
Mirena, ma'am. Levonorgestrel intrauterine system, ma'am. releases 20
Microgram
of
LNG
daily, ma'am. And it can be used for 3 to 5 years.
Very good. So,
What is the
yes, Dr. Dina?
recurrence rate after your primary surgery?
It varies from 2% to 20% in first year, and after 5 years, it is 40 to 50%. 40-50%.
Okay. So, agar if this female would have completed the family and she would have been around 36, 38 years, what could have been done? Medical, not responding to medical management.
Ma'am, we can give a definitive management, which is total abdominal hysterectomy with bilateral salpingo-oophorectomy, ma'am.
But 36 we cannot do such.
So, if you are not going for salpingo-oophorectomy, what will happen?
Ma'am, then recurrence will be there, ma'am. If you're not removing the ovary, then chances of recurrence are very high.
Right. So, if you remove the ovary in a younger age, what will be the problem?
Ma'am, then
They have to give a
OCP. Ma'am, then we'll give a low dose OCPs, ma'am, so that she doesn't have hot flushes or vasomotor changes or any menopausal changes. And we'll also give a calcium supplements, ma'am.
Okay, so you have removed the ovary. Today you have done the surgery. From tomorrow we will start these low dose OCP or estrogen therapy to this 36-year-old lady.
Yes, ma'am. We can start, ma'am, from the first cycle only, ma'am. If we start,
there is no cycle.
ma'am, we can start after ma'am surgery, because starting of the OCPs after surgery, even after lab surgery without TH and bilateral salpingo-oophorectomy, the recurrence rate decreases, ma'am. If we give the medical management after surgery, and ma'am, ISHRA recommends if the patient has completed family and there is no infertility issue, then we should give the medical management for 18 to 24 months after the surgery.
I would like to have Dr. Reva's comment on this take of starting the estrogen therapy after surgery.
That's what I was going to ask, that why they are doing OCP.
Yes.
What is the role of, what would you advise if you had to do a hysterectomy in a young lady? Would you give an OCP? Why are you giving OCP? What is the role of the estrogen? What is the role of the progesterone? You said OCP you want to give, no?
Hormone replacement therapy, ma'am.
No. So hormone replacement therapy is conventionally what? Estrogen or estrogen plus progesterone?
Estrogen.
So why are you talking OCP?
No, ma'am, we will get estrogen, ma'am. Low dose.
So think about it. It's not such a straight answer.
So, take your 2 minutes. In the meantime, people can write down on a chat box also their suggestion, their takes. And what will happen if you immediately start this hormone replacement therapy in a post-surgery patient, which will be mainly estrogen. Somebody has written low dose estrogen can be given, but there should be a gap. Whenever you are starting post-surgery, you might not have removed all the implants there. And if you start up immediately, those implants can regrow and your problem will recur. So if you give some gap of 2 to 3 months so that they regress spontaneously, that will be a better option. Number second, what is the disadvantage of giving estrogen in immediate post-operative period? Patient of yours is at high risk of what?
And thromboembolic events.
And estrogen is?
It can cause thromboembolism.
I hope, Dr. Reva, this is right. Any other reason?
Yes, certainly. It is good. It is fine. What can be done also is to cover the residual endometriotic implants. You can give a little bit of progesterone immediate post-op also, and tide over those 1 month or so in which that progesterone might work to decrease the size of those implants, and after that estrogen can be started.
Yes, that's These are all the practical things which one can do. And these are written somewhere also in the books and your guidelines. If you go read in between the lines, you will get all these things in the guidelines. Okay, so what are the methods of fulguration when you are seeing the endometriotic spots during surgery?
Can be done, ma'am, by using bipolar cautery, unipolar cautery, or CO2 laser.
Have you seen CO2 laser?
No, ma'am, it's not easily available in India, ma'am, due to its high cost.
So mostly we are using bipolar cautery, but unipolar away from ureter, that can also be used. So your patient was having an appendical endometriosis also and a bowel endometriosis, so far as remember. So what can be done whenever there is a bowel endometriosis?
And for bowel endometriosis, we have three options. One is shaving, the second is disc excision, and the third is the segmental dissection. Ma'am, it depends on where the implant is actually present. Above the sigmoid colon, whether it's present in the sigmoid colon, it's present in the sigmoid rectal junction, or it's the rectum, ma'am. Ma'am, if it is present above the sigmoid colon, and if it is present 3 centimeters, we can do a disc excision.
Or shaving.
We can do a shaving, ma'am.
Removing layer by layer, ma'am.
One by one, please. You are jumbling up, huh?
If it is less than 3 centimeters above the sigmoid colon, ma'am, we can do a disc excision. And if it is more than 3 centimeters, we can do a segmental dissection, ma'am. Ma'am, if it is on the sigmoid colon, less than 3 centimeters should be shaving. More than 3 centimeters should be, ma'am, disc excision. In the sigmorectal, ma'am, maybe all the attendees might be getting confused with this treatment, but bowel endometriosis management you should be knowing. And there is a beautiful chapter in recent advances in obs and gynae in a book, one of my books. You can go and take all the, Dr. Reva is also editor of that. So you can see that chapter is very good for an extra ovarian endometriosis, concise chapter that is there. So you all can go back and understand and read from that chapter, or you can go to my website also. Right. So Dr. Dina, any other question?
Yes. When would you plan a pregnancy or ask the patient to start planning a pregnancy after surgery?
So next cycle, ma'am. After surgery.
Immediately after.
Immediately after surgery.
Okay. So we have discussed, I think, majority of the portion of the endometriosis. It is not a very vast topic, which we tried to cover most of the questions, and rest of the things you should be reading ASHRAE guidelines. That is very important. 2022 release is there just in the last month only. So you should be seeing those 2022 guidelines of ASHRAE. And what is ASHRAE, Dr. Astha?
Ma'am, European Society of Reproductive Medicine.
Human reproduction.
Okay. So this guidelines are the latest one, and even AFS is also endorsing this. So please see these guidelines. If you can't read whole, just read the first 3-4 pages where they have summarized what has to be done in which condition. Right? So
there are some questions.
Yes, ma'am.
There are some questions. Maybe we could just go back and look at them so that we can answer
them.
Dina,
Dr. Dina, can you just ask so we can answer this?
Ma'am, pardon, ma'am, I could not.
You just go back to the chat box and just see what are the questions which are there. We still have 5-7 minutes.
Yes.
One question is treatment of lung endometriosis.
Lung endometriosis.
So please go to the that chapter beautifully, because it is a very vast topic. Thoracic endometriosis, there are available thoracoscopic in guidance. Dr. Nazhat has very beautifully elaborated on that topic. He has a name. He is the master of that endometriotic surgery. So you can please go through that chapter, because that has to be removed, because patient generally present with catamenial pneumothorax can present, or recurrent hemoptysis is there. So patient can present, and the only treatment is the removal of that mass, because generally these progesterones does not affect these very far away of lesions present in the body.
Next
But please
question.
go through that.
We have one question. Can ovulation induction drugs be given in a patient with unilateral endometriosis size 4 centimeter?
Dr. Astha and Dr. Anamika, first you take, then we can give the answer.
Yes, ma'am, it can be given, ma'am. If the patient is not having symptoms of any pain, dyspnea, it can be given, ma'am. And if the tubes are normal, it is normal.
So to summarize, we can say this can easily be given. The letrozole or clomiphene can be given to these patients. There is no problem. But yes, if you are giving a estrogen therapy, there are chances of recurrence, increase in size. So you need to be very careful whenever you are prescribing these medications, and you need to monitor, and you need to decide upon when you have to take these patients for in vitro fertilization, because larger the size of endometrioma, there will be a difficulty in taking out the these follicles during in vitro fertilization.
In the chat box, ma'am, we have differentials for anechoic cyst. They have functional cyst, then they have written follicular cyst, luteal cyst, corpus luteal cyst, luteoma of pregnancy. One has written dermoid, but
Dermoid is
will
not
be anoic.
One you have left, par-ovarian cyst.
Yeah, they have written para-ovarian cyst.
Very good. So you need to know the differential. Now, commonest. So you need to serous cyst, simple serous cyst and para-ovarian cyst. Anechoic दिख रही है तो यही है ना? So you need to take care of these things, and you need to watch further whether it is increasing in size or decrease. This is a totally separate topic. Okay, what next?
Ma'am, we have a question in chat box. Ma'am, how much can we rely on ultrasound findings?
I think you should not be relying on the ultrasound finding. You should be relying on your ultrasonologist.
Then there is a question, ma'am, is there any upper limit for CA125 being raised in endometriosis? Is it possible to have 256 CA125 with 8 centimeter endometrioma?
Okay, Dr. Anamika, will you like to take this question?
I didn't get the question, ma'am.
How much rise can be there in a CA125 in cases of endometriosis?
200.
Generally, it is 200, 256 is a borderline, so you have to decide upon. Right, ma'am?
Ma'am, what guidelines do we study about it?
Type karoge ASHRAE, whosoever has given. So ASHRAE guidelines 2022 will come. So again, I will request all of you to please read this topic thoroughly, because you are deficient in gynae topic. So all of you should be reading very common entity which is being encountered. And one more request is there, that please go to my website where practical things are there, like CTG and other courses which you should be subscribing and understanding. These are the things to improve your practice, not just to involve into the viva only. You just read for the sake of passing the exam. That should not be the aim. You should have to improvise your practice, and that should be the aim in each and every one of you. Dr. Reva, ma'am, can you please just comment upon and give your final take?
I think that endometriosis is a very complex issue. And the important point about endometriosis is that a lot of times the management depends on the symptomatology of the patient, the age group of the patient. So a lot of times you basically need to individualize management. You can't, it's not a one size fits all. And you must always counsel your patients very, very carefully, especially when you are taking them up for surgery, because there could be issues about recurrence, there could be issues about infertility. So this consent and counseling preoperative is very important, which is something that I think many times gets left behind. Therefore, you all know the medical treatment, surgical treatment, all this. On this issue, sometimes there is not enough talk. So remember that this is also a very important counseling. Otherwise, patients have problems at in the post-operative period, and then it comes as a kind of a bolt from the blue, and especially when the ovarian reserve falls and they go to an IVF specialist and somebody tells them ki surgery galat ho gayi, so then these things become a problem. So be careful. You need to read.
Dr. Shivani?
Yes, so it was a nice and informative class covering all the basics which a student must know. So on behalf of AOGD and the Delhi PG Forum, I would like to thank Dr. Reva Tripathi ma'am for sparing her valuable time and giving useful inputs for this session today. I would also like to thank Dr. Aruna and Dr. Dina. They have really worked hard along with the PGs to make this discussion series so lucid and interesting. The PGs from HIMSR, they have also toiled hard, as we can see that they have left no questions unanswered. And my sincere thanks to Jagsonpal Pharma and Dr. Deepika for giving us this nice platform. Lastly, I would also like to thank our audience and PGs from various colleges for patient hearing, and I hope they must be benefited from this session. Our next class would be on 18th April on hypertension in pregnancy by PGs from BMMC. So with that, sincere thanks to all and very good evening.
So I take this opportunity and present to you EndoReg, our dienogest tablets of 2 mg for medical management of endometriosis. Apart from this, CycloReg norethisterone acetate CR10, 10 mg tablets for freedom from menstrual irregularities. LycoRed, the cell protector, having 100% natural lycopene along with zinc and selenium. And LycoRed Preg sachet of DHA, L-arginine and lycopene. Look forward to meeting you once again tomorrow. Do join us on this webinar ID again. Thank you very much, Dr. Shivani and the AOGD members.
Thank you so much. Thank you.
Bye-bye, ma'am.